Thank you for listening to this PYA webinar recast. PYA is pleased to offer this alternative way to access our thought leadership. This is a recording of a previously delivered webinar. The information is accurate as of the date of the original event. The video recording, slides, and associated material for this and all PYA webinars are available on our website at pyapc.com. This podcast is for educational purposes only. It is not intended to be used as legal advice or an official opinion.
Welcome to today's webinar. PYA understands the importance of clear, relevant, timely information to the industries we serve. So we offer a variety of webinars, white papers, articles, checklists, and other tools, all for free. Subscribe to our e-newsletters, follow us on social media, and subscribe to our PYA Webinar Recast podcast series for audio-only versions of all of our webinars at pyapc.com. Thank you for joining us. Here are today's presenters.
Hello and welcome to our audience today on episode number 4 for Revenue Recharge. Today's episode, Kathy, Reep, and I will be discussing Medicare Advantage, and there's a lot to talk about here. This is a very common and popular topic in our industry today, and we hope that a lot of you are coming back to return to the series. We're about halfway through out of all our episodes. And again, our purpose here is to really help identify net revenue opportunities through all kinds of different experiences we've had in client experiences. And we want to share some of that with you today on Medicare Advantage specifically. We're going to use some slides here today to kind of guide the discussion. But just note for the audience today, we will be sending out we'll reduce this to a nice checklist that you can use in your own offices as well. So we'll share that with you after the presentation here today. So just quick introductions. And again, I'm Bob Paskowski. I'm a consulting principal with PYA. Prior to joining PYA about 9 years ago, I spent about 27 years on the health plan side, most specifically with provider sponsor plans, and most recently running a Medicare Advantage plan. So this is near and dear to my heart, and I certainly want to share a lot of that experience with the audience here today. But since joining PYA, I now lead our managed care and revenue cycle service line. And we're dealing with, most of our clients are dealing with payer provider issues. We're helping them negotiate contracts, dealing with any kind of disputes. A lot of thought leadership on this topic currently in our practice. And even sometimes dealing with having to sit in the chair of an expert witness and help guide through an arbitration process to get claims resolved. So that's been kind of our practice, and I'll turn over to Kathy Reep, who is my colleague co-presenting today.
Thanks, Bob. And it's interesting that we're talking about the issue of Medicare managed care. Because this is in the press every day. So it's good to share the opportunity to talk with you and with the audience on this important topic. I have been with PYA for about 5 years. I'm a senior manager in business development, but spend a lot of time on thought leadership. Been involved in hospitals and hospital revenue cycle for a number of years. Prior to joining PYA, I was with the Florida Hospital Association, and before that, what is now Advent Health Orlando, working on revenue issues and reimbursement issues. So, I think back to Medicare Plus Choice, growing into Medicare Advantage, taking over more than 51% of the Medicare volume out there. So what your role is with the plans and how you interact with them is vital to your success.
Great, thanks, Kathy. Well, let's dive into it here a little bit. And when Kathy and I were kind of downloading and say, how do we want to condense all this activity into a kind of a 30-minute discussion here today, we thought what was important right out of the gate is just to talk a little bit about the Medicare Advantage business model and what are important levers and successes for the MA plans that drive their profits, et cetera. And we kind of boiled it down to 3 major things that really make a Medicare Advantage plan successful. The first is the star ratings, and Kathy alluded to a little bit here that right now with star ratings, it is their quality measure of their performance. And there's approximately 50 measures, a scale of 1 to 5. And basically, they need to average over 4 stars to earn a very lucrative bonus of about 5% of their premium. And we'll get into the dollars here immediately, but in a moment. But you know, those 50 measures, a lot of them are driven from you, the providers. Things like readmission rates and diabetic eye exams for diabetics, et cetera, that really drive their star rating, again, getting over 4 and then earning this nice bonus. And there's been a lot of activity with that whole model right now, getting a lot of press. There's been some lawsuits filed, and Kathy, I think you've got even some recent activity. It's, again, changing every day of what's happening in the star rating space.
Absolutely. It seems that there are a number of plans that are out there who are now challenging the results of the star ratings published by CMS for the 2024 plan year. What we're looking at, and I think this also addresses the how much money is connected to the star ratings as it comes out to the plans. I believe it was Scan Health Plan. They recently were successful in court as it related to a decrease in their star ratings from 4.5 to 3.5%, and $250 million in bonus payments. And then Elevance has also been disputing, and so far they've brought back over $190 million in revenue. So significant reimbursement just tied to the star ratings. That 1% reduction in the ratings, $250 million.
Yeah, so obviously this is a big part of their business model. So again, we wanted to make sure you all are aware of that. That's important to them, and you actually as a provider can help them drive those scores. The second one is around risk adjustment, and I'll kind of make it fairly simple in that every year an MA member is given a risk score. It's based on age and gender and all their diagnoses. So Bob or Kathy might be a 1.0 in 2023, but I'm reset every year and I'm rebuilt up in my risk score. And if my risk score goes from 1.0 to 1.05, that's basically a 5% increase in the premium payment that the MA plans get from CMS. So simple math here is if they're getting $1,000 per member per month for each of their members, and if Bob or Kathy are a 1.0 and we move to a 1.05, that payment goes from 1,000 to 1,050 based on that. So it's so important that the plans are getting all the diagnosis from you, the providers, that they can build these risk profiles and get paid based on that simple math. And then the last one was around the third one. I think that's probably the most critical to them is really they're managing their medical loss ratio. And we all know the biggest part of the medical loss ratio is our hospital costs. So there's clearly an eye on looking at where they can cut costs on the hospital side. And we're going to talk a little bit today about some of the new policies that have come out that have helped to try to mitigate some of that risk. So again, those are the three that kind of drive that business. We wanted just to start with that to understand what we're going to talk about today. So we've come down to basically 3 items that we think are important from a net revenue opportunity perspective as it relates to Medicare Advantage. The first one, and we'll dive into these more specifically, is monitoring your contract yields by MA payer. The second one is around these policies that impact reimbursement. And finally, just seeking value-based opportunities that can supplement your revenue. So those are the 3 we boiled it down to. So let's start with number 1 here. And again, monitoring your yields here. So the first one is using any kind of data tools to monitor your results here. And let me just take a step back and say, when we say yield, we all write contracts between our provider's system and an MA payer, and that sets an expected reimbursement. So the contract may say we're going to collect Medicare rates. So that's, let's say that represents $1. So that's what you expect to be paid. And then you start billing and you start getting paid, and guess what? The dollar doesn't materialize on every one of those claims. So if it comes in at overall at 90 cents on that dollar, your yield is only 90% on that contract. So it's a matter of watching that. I will share a client example that they looked at all their Medicare Advantage contracts and looked at that yield, and it was in the low 80s. And that's significantly less than what they would get paid for Medicare. So that's a business decision that they have to make with those particular rates. The second one here is,
well, before you go there, Bob, just on those reporting tools, I mean, it's really easy to say, make sure that your payments equal your expectations and that you're getting paid what you contracted for. But particularly for, you know, well, I guess both PPS hospitals and critical access hospitals, when we start looking at add-ons that you get under the fee-for-service Medicare program, you need to make sure that you're getting those same add-ons under Medicare Advantage. So if you are a teaching hospital where you get a teaching adjustment, or you are a disproportionate share hospital and you get that additional revenue, or on the rural side, perhaps a low volume hospital, designated low volume. Again, you need to make sure that if the plans are paying you as Medicare fee for service, then that you are getting those additional add-ons and that they're actually flowing through to you on your claims or through some sort of settlement process.
Yeah, great point, Kathy. And the other thing is, sometimes we get clients to ask, can we get more than Medicare? Absolutely, you can. You can ask for 105%, 110%, again, whatever the market will bear, because you will see some drift downward just because of denials of claims or whatever that gets that yield lowered. So certainly you can ask for higher than Medicare rates. The other one that we put in here was around your contract language, specifically around these unknown provisions affecting reimbursement. And I think we probably all realize a lot of these kind of sit in a provision that may say you must follow the provider manual or all administrative guidelines, those things. And kind of behind the scenes, those guidelines could have an effect on reimbursement. So we've seen quite a bit of activity in this space where we've tried to amend that language. And I think as we're talking to and helping our clients with these payers, we're getting some good movement on that. So again, just something to be aware of, that these are things that we want to make sure that don't affect your reimbursement.
And one on that, Bob, that I wanted to call to everybody's attention, particularly with a critical access hospital that might be being reimbursed as Medicare, which would be the 101% of cost, at least for most of the hospital services and swing bed services. You tend, very likely, you might sometime during the year get an adjustment to your rate from fee-for-service Medicare, a retroactive rate adjustment based upon a more recent Medicare cost report and the audit of that cost report. Need to make sure that you've got contract language that requires those managed care plans who are paying you under as fee-for-service Medicare, they also pay you those additional dollars through those retro rate adjustments. Very important that if your fee-for-service rate has gone up retroactively, you're getting a lump sum payment, then you need to make sure that this is also flowing through to your Medicare Advantage population.
Yeah, which leads us to the third item around just keeping up with your current rate changes. And we really try to push for trying to get those rates anchored to some percentage of Medicare. And so as Medicare goes up, your Medicare Advantage rates can go up as well. So again, just something to keep in mind there with making sure you're keeping up to date on all the Medicare rate changes that flow through your contract.
And you might want to include contract language that addresses how quickly a plan has to move forward with the new rates. For instance, with a hospital paid under the inpatient prospective payment system, you know that at the end of July or early August this year, you're going to get detailed information in terms of what your rate is going to be as of October 1. How long do you give the plans to adopt those October 1 rates? Do you give them 90 days? Do you make them be retroactive back to October 1? But make sure that you address the effective date of those new rates within your contract, when they should be ready.
Yeah, thanks, Kathy. All right, so we'll move to the second item, which is around the policies. Kathy, I think you want to take this one.
Sure. The first issue, and Bob, you're driving the slides, so you can see as I jump from one topic to the other. But the first issue on the 340B hospitals, there was a final decision. This has been an issue that's gone back and forth for several years, but a decision issued by initially the courts and then the response from CMS in terms of how they were going to make retro payments. But essentially for 340B hospitals, there was a reduction historically in your payment rates. For most drugs, you were paid average sales price plus 6%. For 340B drugs, they changed it to average sales price minus 22.5%. So a huge change in the reimbursement for those 340B drugs. Number of hospitals and the American Hospital Association litigated this issue. The courts decided that the action taken by CMS to reduce these rates without having done a survey or done more detailed analysis, that they were in violation of the rules. Therefore, they had to make hospitals whole. If you are paid under Medicare Advantage as Medicare fee-for-service, they need to make you whole as well. There is not, CMS will not step in and say 340B, Medicare Advantage plans, you need to process retro adjustments as well. However, they have been very clear in their final rule and in their documentation saying this is a retroactive rate adjustment. And therefore, if you have a contract in particular that says retroactive rate adjustments are made, then this is a retro rate adjustment to the prices of drugs, and the plans need to make you whole. If you did not have that retro adjustment language within your contracts, I think providers are still going back to the plans and insisting on that additional payment.
Yeah, this is a big one that if you're not aware of this and you were a 340B hospital during those retroactive periods, 2018 through 2022, there's an opportunity there that you need to at least be researching on that opportunity if you have MA contracts, definitely.
Well, and the thing that's important about that is when this was implemented, it was done in a budget neutral manner so that you got a negative payment for your 340B drugs, but everybody got a boost in their payment rate, their base payment amount under the prospective payment system. Now, what's going to happen is they're going to lower your payment rate for 16 years for your base payment amount, but give you that retro money under 340B. Again, if a plan is paying you as fee-for-service Medicare, they're going to be paying you less for your base payment. So they'd almost be double dipping, I think is the term that was discussed.
Yep.
If they don't make the retro adjustments. Prior authorizations, that's, I guess, one of the biggest headaches I think providers are seeing right now with the plans. I guess it would be prior authorizations and other types of denials. But we have been fortunate enough, I think, to actually get some attention from the Centers for Medicare and Medicaid Services as it relates to prior authorization. There are new rules that will be effective in January of 2026, basically saying that the prior authorizations are going to have to be addressed within 72 hours for an emergency, an urgent request, and 7 calendar days for other requests. And one of the questions that was raised to CMS is who decides when the request, who decides urgent versus other. And it is based upon the physician who is requesting the authorization or the entity requesting the authorization. So again, a positive change for providers. When you want to appeal a reconsideration under the new rules, that reconsideration must be conducted by a physician. When you request an authorization, it could be a physician or another healthcare professional, but reconsiderations have to be decided by a physician. And if they have, if they cannot retroactively deny a service as being medically unnecessary if they have previously authorized it, unless there is evidence of fraud. So I think that is another win for providers. The plans are not going to be able to use interqual or Milliman or any proprietary criteria for making determinations on prior authorizations or even medical necessity. So I think we have been fairly victorious in this particular issue. It's just got to stay in there a little bit longer. But in the meantime, I would start right now tracking your PA rates, your response times, your outcomes, and then compare that to data next year when the new rules are in effect. If it hasn't gotten better, we need to be talking to CMS, both through your regional office and through the central office in Baltimore.
Yeah, I think this is good movement. And again, it's coming, and again, there's no reason not to start today to try to again push some of those issues and try to get those that process working a little bit better. But that's, again, this is a net revenue opportunity of trying to get those through more timely.
Two midnight rule. This was a part of a final rule that CMS issued last April. As it relates to Medicare Advantage plans and really addressing the coverage and utilization criteria for Medicare Advantage enrollees and making sure that they were treated as a fee-for-service enrollee. Essentially, the same rules should apply. So whether it be a local coverage determination, a national coverage determination, or a general criteria for service that CMS has established, such as the 2 midnight rule, the plans are going to have to follow these. They do have to follow the 2 midnight rule, which means that if a physician documents upfront that he expects the patient to stay at least 2 midnights in the hospital, even if the patient doesn't stay 2 midnights, if that expectation is documented, and I do mean documented, why? Don't just check a box, expect 2 midnight stay, but why do you expect a 2 midnight stay? Even if the patient doesn't stay, it's going to be covered. The Medicare fee-for-service program also has a 2 midnight presumption that basically says if the patient has stayed more than 2 midnights, we presume it was medically necessary, and they have very limited audits on that. The plans do not have to follow the presumption. So it's the benchmark up front, the documentation up front that your physician expects the patient to stay. On all of these issues, prior authorizations, the coverage and utilization rules, 340B, you have got to exercise your appeal rights. You can't be quiet. If you are being inappropriately denied, track your denials, track your appeal outcomes, and as I mentioned on the issue of prior authorizations, again, when there are violations of federal policy, you need to let somebody know. It's going to be your regional office of CMS and the central office as well. At least make sure that they've been notified.
Yeah, and these will all be tied in somewhere in your contracts too, that they won't be specifically layered out, but they will be referenced, and you know, make sure that language ties into some of these upcoming policy changes. Thanks, Kathy. Okay, we'll move to our last one. Our last one is on value-based value arrangements. Again, another opportunity for additional revenue to come into your organization. And as we talked earlier about the business model and what are the key elements of what's driving the Medicare Advantage plans, you know, as we talk about with star ratings, providers provide a lot of that value is to go into that star rating. So why can't the providers monetize that activity? On the risk adjustment side, again, it's based on diagnosis that are coming from the providers. That's, again, driving their risk profile and how they're getting paid. So it's a matter of taking those elements and trying to figure out in these value-based arrangements how additional revenue can come in. The first is on quality. We've seen, yeah, go ahead, Kathy.
I was just going to say on the star ratings, we said early on that Elevance, Scan, others have been appealing their ratings and getting them bumped back up. So if you have a value-based arrangement and they're getting a $250 million bump because they aren't a 3.5 now, they're back to being a 4.5, shouldn't you actually be able to benefit from that as the provider as well?
Yeah, and we'll talk about that with this third one, but we've seen even some arrangements where, whether it's a readmission rate, which we know is a star rating, if we lower to this, we can earn additional dollars in their contract. So again, there are specific quality metrics that are inserted into these value-based arrangements that you can earn additional dollars on top of your fee-for-service dollars. But again, that's why we wanted to share with you at the beginning that it's important to them, and you're driving some of that value. So why not try to get some additional income from that? The second one is around operations based. We've seen agreements where, you know, filling out health risk assessments, doing care management. Again, it's helping the health plan manage their medical loss ratio, getting patients in the right care settings. All those things are driving value to the plan, so they're willing to pay. And so we've seen and negotiated some of those revenue sources coming back into the providers. And the last one Kathy kind of alluded to is population based. So if your health system is has an employee group that's managing, let's say, 5,000 Medicare Advantage patients, you almost insert yourself just like a health plan. Well, you'll take the risk on them, whether you want to take full risk or shared savings. Those elements we can talk about separately. But you're managing the whole cost of care. So the fact that your health plan is getting a 4-star rating or greater just puts more money in the pool as available for distribution. So again, those are key things that we're finding a lot of organizations getting opportunities presented them from their MA payers that says, hey, can we add some of these elements to draw additional revenue to you, which again helps them. So we wanted to point at least these 3 out. Anything to add on that, Kathy?
No, I just think it's important to know. I said no, but yes, I do have something to add. I think it's important to stay aware of what's going on with the payers that you contract with when they have been successful in litigation to boost their reimbursement, things like that. Make sure that you're aware of that, and that if it's something that you are directly or indirectly, it impacts your reimbursement, then you need to raise that with them and make sure that you benefit as well as the plan.
Great, thanks, Kathy. So we're going to conclude there. We want to thank our audience for joining us today, and we hope to see you again in an upcoming episode of Revenue Recharge. Thanks.
Take care.
Thank you for listening to this PYA webinar recast. The video recording, slides, and associated material for this and all PYA webinars are available on our website. If you have any questions or if we can help, please contact us at pyapc.com. Thank you again for joining us, and have a great rest of your day.